Hello, welcome back from lunch. I'm John Hooton from Mount Sinai, New York, and I'm going to be moderating this exciting next segment on cervical disc arthroplasty. I think that anyone who's been practicing 15 or 20 years remembers the excitement and the energy in the air when disc arthroplasty first became available. And then 10 years later, I think there was a widespread disappointment that it didn't make as big an impact in the average surgeon's practice as we thought. But I think that there is a change in the air now again, that we're understanding this technology better and understanding better how it might be applied. And now the coda for this section on motion preservation, athletes, high-performance athletes and disc arthroplasty, Sheeraz Qureshi.
Great. Thank you, John, and thanks, Jason and Max, for inviting me to give this talk and including this in the ICL this year. And just as a shout-out, we did a focus issue on cervical disc replacement as part of Clinical Spine Surgery Journal, which was a CSRS issue, and that'll be available starting tomorrow. I think at the meeting will be handed out, and I think all of us have published in that. So I think it'll be a great issue. So my topic is cervical total disc replacement in athletes. It's a very controversial topic, but I also think timely. And the punchline will be that we're not sure, but I'm going to go through this anyway. So the objectives of the talk are sort of just to kind of start thinking about the implications of a cervical injury in professional athletes. But I think, for a lot of us, and, the focus will be a little bit on professional athletes, but in general, I mean, we all have patients that, want to do things like play tennis or play soccer or ski, and those are all things that we need to think about when we're thinking about recommending something like a cervical disc replacement in these patients and the trauma that that they may undergo. If we are doing a cervical disc replacement, we want to be considerate about sort of what the goals of that treatment are, and then we'll do a literature, just kind of go over what the current literature is for these procedures. So in terms of athletes and cervical injury, I mean, clearly, especially professional athletes and certainly American football, rugby, and hockey are three significant collision sports, and there is an increased incidence of cervical spine injuries in people who play these sports at a high level. So I think these sports can be considered risk factors in general for cervical injury, as well as lumbar issues. So that doesn't mean that we should be advising people not to participate in these sports, but it is something that we want to be cognizant of, and it has to do a lot with repetitive loading and certain ways of tackling or collision. But some of this is just unavoidable. This is just an example sort of cervical disc herniations in NFL athletes. And when we think about sort of what the risk factor is in the general population versus in NFL athletes, you can see just sort of at the age where people get cervical disc herniations. If you're an NFL athlete, you're going to have this problem in your 20s versus the general population, where this is really a problem of people in their 50s. And herniated cervical disc is can be a career-ending injury. And if you think about, we're all surgeons in the room. If you had a risk of having an injury that was going to have a 30% chance of ending your career as a surgeon, that's a pretty big deal. So it's certainly something that you want to think about when we're taking care of these patients. This was a nice paper. Jason was one of the co-authors on this with a couple of his partners, and I think an important one, just looking at the impact of diagnosis of a cervical spine issue on the career of NFL athletes. And it was interesting because if you think about sort of like the draft position, and I have a couple of these things highlighted here, but you could see, if you went into the draft with some sort of a cervical spine pathology that came up on your combine, and I don't know if any of you guys have ever been at the combine, so it's like it's like just getting stripped naked when you get to see like these all the information medically on people, and if you had something come up and you were a linebacker or a defensive back, the likelihood that you were getting drafted was extremely low. And that's why you can see 100% of drafted linebackers, for example, did not have any cervical spine pathology. That doesn't mean linebackers don't have cervical spine pathology. It just means if you do, you're not getting drafted. And so when we think about, sort of the standard of care in athletes has either been, especially football players, hockey players, sort of collision sports, has been ACDF or cervical foraminotomy, depending on the problem that we're dealing with. So why think about, changing something that works? And some of this has been sort of brought upon really by the athletes themselves. I think, we're probably all pretty familiar with the couple of the hockey players. I think one, Jack Eichel may play in Vegas if I'm not mistaken, but he sort of, it was in the papers so we could talk about it, but it was a real push towards, sort of saying I should be able to have a disc replacement and still play, because people understand some of what we've heard, which is that you do have this higher risk of adjacent segment issues and problems potentially in your future of needing more surgery. So when we're thinking about treating any kind of athlete, what are the goals of care? So this is a little bit of a busy slide, but again, the point here is that it's multifactorial, it's a complex decision when we're thinking about how to come up with the right treatment plan for anybody, but there's these added things for a professional athlete or somebody who has aspirations of being a professional athlete, because this is gonna have a significant impact, not just on how much time do I have to take off from work or recovery or what, but really, am I going to be able to go back to the job or the profession that I'm involved in? And so, we certainly need to take into account the desire to return to play, the type of sport that they're involved in, and what the career longevity sort of looks like, which are things that you might not think about when you're treating a non-athlete for these same problems. Obviously, there's always options of operative versus non-operative interventions, and it's always interesting because you would sort of, I think the instinct for most people is to say, well, if we could treat something non-operatively, maybe that'll be better, right? And I think that a lot of us, when we see patients in the office and we're dealing with somebody with a cervical disc herniation and radiculopathy, there's no cord compression, there's no weakness, and we say, you know what? You're going to be fine. You probably don't need surgery on this. But interestingly, if we think about athletes and their ability to return to play, this was a really nice article by Wellington Sue. And if you look at the non-operative group, you had a much lower incidence of return to play in professional football players, at least, if you were treated non-operatively versus if you were treated operatively. So, you do want to be cognizant of the fact that, when we offer a surgical intervention, it can have a significant impact in terms of improvement in symptoms to be able to allow somebody to return to a high level of activity. This is, none of the studies are perfect in any way, but certainly something to think about that, sometimes being conservative means performing a surgical intervention. It doesn't always mean non-operative. So when we think about treatment considerations, like we just heard in the last talk, when we're thinking about single-level cervical spine issues, and we'll sort of limit this talk at least and the concepts here to single-level issues, because if you add a second level, it leads to like a whole nother set of considerations. But you're really thinking about ACDF, foraminotomy. Those are sort of the gold standard, so to speak, and then we're introducing this concept of could you do a disc arthroplasty in a collision athlete? And again, I think as you'll see, I don't have the answer to that, but I think the literature is what it is. But if we think about the treatment considerations, we want to get a neural decompression. You want to try to have stability, obviously, perhaps restore disc height, and ultimately try to preserve range of motion. And that preservation of range of motion is where, sort of the disc replacement and the foraminotomy have their potential advantages. And what the benefit of that, I think, is, at least in a sport per se, it's hard to know, but I would say that I think it's more about, what you heard in Andrew's talk, where, kind of the longer-term follow-up on these patients does show that there's a reduced incidence of need for a second operation, either at the same or adjacent level. And if you can get an athlete back and you can get them back safely and hit all your goals, and they have a lower risk of needing another surgery in their future because of how you treated their first problem, then we should at least be thinking about it. So what's the literature out there? I will tell you, it's pretty sparse. So this was a nice paper by Andy Heck, Joe Maroon, Wellington Sue, as well as some others, looking at 101 professional athletes, and you could see only 2 athletes in this group had cervical disc replacement performed. They were both baseball players, so you wouldn't necessarily count that as a collision sport per se, but certainly, there are times in baseball where you could have a collision. You could see that the results around disc replacement are limited, and certainly posterior foraminotomy kind of remains, as we would think, the gold standard, but the indication for these surgeries may not be exactly the same, and I think that that's an important consideration. In terms of return to sports after cervical disc replacement, this was a paper just not necessarily looking at professional athletes, but just looking at patients who had cervical disc replacement done and their ability to get back to sports. So sort of, the kind of patients that I'm sure that we all take care of that just want to get back to things. And you can see that the ability to return to sort of sports in general after disc replacement is very high. And certainly things that, we would consider not really contact sports, I think it's probably something that we don't even really need to think about. But if we look at sort of this was a systematic review that we performed just at overall, what is the information on cervical total disc replacement in athletes? Again, there's just not a lot out there. So while on the one hand, we could say, well, 100% of patients return to sports based on these 7 studies, it's important to consider that 4 are case series, 3 are case reports, and overall, our N of patients here is only 57 patients. So it's a very small number. So I think certainly a lot of opportunity out there for study, and hopefully, our society will provide further information on this. But something that I think is important for us to be thinking about, because the athletes are coming asking for these procedures, and we need to be able to inform them properly. So I'll end there because we're on time, and thank you very much.
Okay, I think we have time for a couple of questions. You can come up to the mics while we're waiting for the audience. I could ask any of the panelists. Few people need a surgery because they have a perfect disc segment. And I think that there are some authors who have talked about more spondylosis being tolerable. And I want to know what your attitudes were about doing disc replacement on a patient with some degree of spondylosis and where you would draw the line.
I can start, John. I think it's an important point you bring up. I think the original studies talked about loss of disc height to a certain extent being a relative contraindication. I'll say in my own practice, as I've gotten better at doing disc replacements and I feel more comfortable getting like really good releases, my primary contraindication is if there's facet arthropathy. But disc height and uncovertebral arthritis, I feel better about doing an arthroplasty, but I do that operation differently than I would for a soft disc herniation, because I do really spend a lot of time sort of getting out with a kerrison and sort of biting out and really making sure on an AP radiograph that we're restoring the uncovertebral height. But yeah, I'm curious to hear what others think.
Yeah, for me, disc replacement is a disease of soft disc herniations. And so I really tend to shy away from those spondylotic patients in their 50s, 60s, and 70s. I really do, because I think they go on to have higher failure rates, and it seems to be, need fusions, need revisions, and so forth. So I shy very much away from that spondylotic patient to a great degree, certainly somebody with facet arthropathy.
Any other thoughts?
I agree with that. I tend to steer patients away who are in their 50s, 60s, 70s with a lot of facet arthropathy from arthroplasty. Now, some of them still want an arthroplasty, and they don't really care what you think. They have read on the internet that it's going to be the next greatest things in sliced bread. They're getting an arthroplasty one way or another. I will say that I went to Taipei as visiting professor, and they were basically putting an arthroplasty in everyone who walked in through the door, and they even have some people with OPLL, mild OPLL, they're putting in arthroplasties. And I thought, this is weird, this is not going to turn out well. But actually, They publish the results in JNS Spine, actually turns out okay. It's not like the patients are, having terrible revision rates. It's not as good as someone who's young with a soft disc, which is my primary indication for doing it, but it wasn't terrible even if they put it in these spondylotic people.
Sheeraz or Praveen, do you, if you have a patient that's very spondylotic, which sort of implants do you use? Does it influence your implant choice?
Yeah, for me, I primarily use a keeled implant just because I like the stability and being able to tell people, that I'm comfortable with them getting back to things. The spondylosis probably has less impact, but sometimes if there's a really collapsed disc where I'm worried, then I'll lean towards one of the devices. Simplify has like the kind of smallest option available that we could still get in. So that's a small consideration.
From the front.
Sang Lee from Johns Hopkins, Baltimore, Maryland. I got a comment and question about the frame anatomy with the disc arthroplasty topic. So I totally agree with that. Prior frame anatomy is okay with the disc arthroplasty because a few points. Even we think we remove the 50%, if you check the CT scan, it's much smaller. And also, the facet joint is growing back over time. It's in the literature. It's up to 30-40%. I think that's okay with the stabilizing facet. But I think at that point should be tailored because some posterior pathology could be a contraindication of disc arthroplasty. That's the comment. But question to the panel, what about, I don't have any experience with frame anatomy after disc arthroplasty. So I'm going to ask questions, experience, any thought?
I think, based on the work we did researching this, I think it is a perfectly viable option. We don't know what the clinical outcomes are. There's really not any existing data. It'd be a great paper to be here at CSRS in the next couple of years. But I think the most important thing, and the thing that I tell everybody, is you just want to make sure you're not sticking your head in the mud with some other problem with your disc implant, mechanical complication, device-related complication that you're ignoring and doing a frame anatomy. You could certainly make that problem worse.
Are we still worried about debris and longevity of the implants? I have heard very few people speaking about that lately.
I'm not so much worried about it. I think that's much more an issue of lumbar arthroplasty and large joint arthroplasty than is for cervical. The cervical motion-bearing surface is so infinitesimally smaller than those other ones. I have not seen an issue with wear debris and all kinds of foreign body reactions. Or I'll say I have seen it maybe twice in a decade.
Yeah, I agree with Praveen. I think a well-done arthroplasty, you probably don't have that issue. I think if the implants were sized too small or there was like too much end plate removed, there was this issue of like HO or subsidence and probably early wear. There have been some reports on one of the implants in particular having some issues with wear rate, but I think it's debatable. I think most of it just comes like if you're doing an arthroplasty, it is a different operation, and I think the point that Praveen made in the first talk where unfortunately, we get paid less to do a harder operation that, can go bad in a lot of ways is unfortunate.
It's the elephant in the room.
Yeah.
The front.
Drew Bednar from McMaster University in Ontario, Canada. I came up to ask my question just before you started that discussion, and it's a nice synchronicity. I have experience with about 150 cervical arthroplasties before the Canadian Budget Police caught up to me and shut me down. But they were very early in the release, so they're late. We have lots of 2-year outcomes data that's pretty good, and I followed my people for that year or so and said goodbye. I've had several come back with really problematic late ankyloses in the 8 to 10 year range, and they're ankylosing in flexion when their baseline alignments were very, very good, which I think I can explain, but it's a little flaky. I'd like to ask the panel if they have any experience with this, because it's a really thorny late problem to deal with. The revisions have just been awful.
I'll take a shot at that. The ones that I've seen ankylose have ankylosed in a neutral, basically straight, neck position. I haven't seen them ankylosed in a kyphotic position. Maybe once or twice in a long time that I've seen that. So I don't know if that's related to what product you used for your arthroplasty, but for the most part, when they ankylose, they seem to be, for me, ankylosing neutrally.
Are you seeing early ankyloses or later ones?
No, I usually see it, if I see it, I see it somewhere around 5 years. Because I used to follow them all, when I first did them, I was in one of these, US FDA trials, so we followed everybody, and we were really, really, specific to go find them and track them down. In the first 2 years, it really didn't happen. It was, between the 5 and the 10-year mark that I started seeing some of this stuff. So, but they basically turn into an ACDF in neutral.
Thank you.
Front.
Hey there, Pat McNulty. Can you make a couple more comments on the issue of third particle debris? Because my simple concerns are you've got Scott Blumenthal did a little presentation with revision TDRs, and it seemed like the design with the M6, which has that polyethylene kind of annulus, seemed to have a higher incidence of osteolysis, and that's kind of a different mechanism for third body wear than the traditional poly on metal. And then also make a comment in regards to the simplified disc, which has that ceramic core on peak as its weight-bearing surface. So maybe expand the comments on that, because those are a little different as far as mechanism and basic design.
I have not used the M6, so I can't really comment on that. Shiraz, I don't know.
Yeah, so I agree. I mean, it's very debatable. So this is like, just my opinion. But yeah, I agree. I mean, I think the strands of polyethylene, which are sort of in the core of M6, it has potential to have debris. Now, there are some people that use it and they say it is absolutely not the case. But the ones that I have seen in recent years, especially over the last 2 years that have come into my office, with like early issues of debris, especially where like you could see osteolysis around the end plates, have all been M6. And I don't know if that's just bad luck or if that is a function of the implant. But yeah, I don't use the implant personally. But again, it's just my opinion.
I think it's my opinion as well. And so, not to throw anyone under the bus or anything like that, but it does seem that the ones that I've revised have that osteolysis that is at the superjacent end plate. And it is, I assume, from wear debris.
Yeah, so I'm not familiar with the details of the testing protocols, but obviously it'd be ideal because you got some basic differences in implant design to somehow quantify that third body debris. And, just empirically thinking about the M6, there's a lot more interface, a lot more shearing going on. And I think TBI's done a lot of those studies, and it seems to be an issue with that. But again, the Simplify, for me, one of the biggest deterrents for me to do a disc replacement is simply imaging. But now with the Simplify, it's got peak with the plasma spray titanium and a ceramic core. The imaging's great. So again, but that's a new kind of design. I've never heard of a ceramic on peak as an arthroplasty design.
Yeah, so I've used Simplify, and I agree. The imaging qualities are really, really good if you need to get a post-operative MRI. But I will say I mostly use Prestige LP, which is a metal-on-metal disc. I mean, but the MRI protocols now, the one that we use at our hospital is called the Maverick protocol, which is a metal subtraction protocol, and you can get fantastic. I never have had to, in at least the last 3 years now that we've been using Maverick, have had to get a CT myelogram on a patient due to metal issues. And it really came from large joint arthroplasty where they needed to get MRIs to kind of look around. And so then we started using those for our spine cases as well. And the metal subtraction MRIs are really, really good regardless of arthroplasty type. It still, doesn't compare to obviously the Simplify, which that's like its big advantage. But you can get good MRIs with certain MRI protocols with other arthroplasties as well.
So one more simple point, as you perhaps push more into a spondylitic patient that still has reasonable motion, obviously recurrence at the index level is more of a concern, correct? So The other issue is how's the CT imaging? Because even CT can have artifact as well. And again, it's just, with index level concern of recurrent of disease, the imaging's a big deal for me, so. Comments?
I think with, the two that I use the most frequently is Prestige LP and Simplify. The imaging characteristics, CT and MRI, are manageable with current imaging protocols. I think there are differences in some of these cast more shadow artifact than others. And I think with those two, the Simplify is relatively new, so I don't know what its wear debris issues are going to be 5-10 years down the road. The Prestige LP really didn't have that when we looked at it long-term in 7 years follow-up.
Thank you to all of the panelists. That was a great session.